at the end of this webinar. But for now, we're going to get started. So I'm Dr. Mehta. I'm from MedSchoolCoach and here with the OnlineMedEd coaching guys, and we're going to be presenting a webinar about how to beat the USMLE with Dr. Williams and Dr. Ramirez. I'm going to turn the controls over to Dr. Williams right now. Just want to remind you guys one more time to go ahead and ask questions as you go on the question and answers function, and we'll get to as many of them as we can at the end. And we're hoping for an awesome webinar, so ask away. Dustyn, I'm going to turn it over to you.
Now I have power. All right, so to get started, for those of you who don't know who I am, I doubt you'd be here if you didn't know who I was, but I will tell everyone else who doesn't know me. Until very recently, I'm Dr. Dustyn Williams, Dustyn for life, Dr. Williams for the seminar. Until January, I was the clerkship director of internal medicine at Baton Rouge General. I was APD this year in core faculty for my entire career at Baton Rouge General Internal Medicine Residency Program, satellite campus for Tulane, and a full-time hospitalist. I recently resigned my post there so that I can work full-time in OnlineMedEd, which you probably know. And I feel like it would be a disservice to the audience who doesn't know what that is, at least to not call it out, right? Technically not a conflict of interest because I don't diagnose or treat disease, I don't sell drugs or device companies, right? But at the same time, this is a USMLE talk, and OnlineMedEd is a Step 2 clinical learning platform that helps you study for Step 2. So I'm here in the capacity of, I know what I'm talking about, but the intention of me being here is not to try to sell you on OnlineMedEd. And if you give money to OnlineMedEd, you are giving money to me. So my goal here is not to try to generate revenue for myself. My goal is to really fill you guys in on what I know about the MBME and the STEP. Also with me is Joel. Turn him over to Joel to give his introduction.
Hi everyone, I'm super excited to be here. So glad you're here. I just have to reiterate what Dr. Williams and Dr. Mehta said. I think it's going to be a great webinar. My name is Joel Ramirez. I am the director of USMLE, Complex and Medical School Tutoring at MedSchoolCoach. We currently have a collaboration with OnlineMedEd and provide tutoring services for their students, which is the OnlineMedEd powered by OnlineMedEd coaching powered by MedSchoolCoach. I'm also a master tutor at MedSchoolCoach, tutor for Step 1 and Step 2 CK. And I'm also going to be the new integrated vascular surgery resident at UCSF this fall. Super excited to get this webinar going, guys. These are my conflicts of interest.
All right. So let's get the elephant out of the room. What the USMLE is not. So when the USMLE was first created, it was the United States Medical Licensing Exam. It was designed to find out, do you have the minimum requirements to practice medicine? It's designed to be pass-fail. Well, obviously it's not no more, right? And so what these tests are not is your value as a physician, and if they are not is your value as a human. And being a multiple choice exam, what they are is a value of how well you take multiple choice exams. Unfortunately, it is the only, and I'm going to give you a small argument for why it's good, the best objective measure a residency has for your capabilities, surrogate to practice medicine, right? That is because the USMLE does a good job of testing medical knowledge and clinical reasoning at the level that you're supposed to know it, advancing Step 1, Step 2, Step 3. And because it's objective, and because it's a multiple choice exam, it's infinitely scalable. You don't have to get a guy who doesn't like the way you look giving you a bad score so you don't pass. So it's not the best, but it definitely is the best we have. And I think that if, as we get through this, you'll hear about certain rules that are in play for the MBME shelf exams, as well as the MBME's USMLE STEP and COMLEX exams that make it fair. So this talk is mainly geared at Step 1 and Step 2. Step 3 sort of follows the same rules, and then the board exams get a little bit further out. So I want to start it off by what's the difference between Step 1 and Step 2, right? Step 1 is mechanisms, how things work, how they break, and how pharmacology influences those systems. Step 2 transitions to more into management, making the diagnosis, knowing what tests to get, and what the initial intervention is. Step 3 is more about, hey, you did that initial intervention, how do you follow up? And the the thing is that these tests do a good job, and I'll show you why, at testing your medical knowledge and your clinical reasoning. But at the end of the day, they are a multiple choice test. So if you want to do well on these things, you have to learn how to tackle the multiple choice test taking as well as learning the stuff. All right. So who has heard of an illness script? Now you can't respond. But medical educators like to throw this term out there, oh, the scripts, blah, blah, blah. What is an illness script? What is it for real? So I like to think of an illness script actually very much like a script for a play, right? A live performance. If you go to a play, you know that the actors on stage have a script to read, right? And their goal is to perform that play exactly the way they're supposed to, exactly the way the script says, and exactly the way the director told them. If you go to one play, you see a performance. You have no idea if they did it right or not, right? They do because they've done it over and over and over and over and over and over again. But you see a performance. You're like, oh, that was good. If instead, though, you watch the same play for 30 days straight, twice a day, at the end of those 60 performances, you're going to know when, hey, Sally took 2 steps too many. And when the light switch was flipped and the lights didn't go off, uh-oh, they're really screwed up. I want you to see that that person who has seen 60 versions of the play and knows the subtle differences and, oh, God, that was not supposed to happen, is me, right? I've seen 1,000 COPD exacerbations. So the ABIM board exam is going to assess, oh, and also what the slight variation. The USMLEs, on the other hand, are designed for the person who's seen that play once. That is to say that there are illness scripts, and what they're going to be testing is the 0 standard deviations from the mean, the classic presentation, which means that the USMLE exams are centered around not how much do you know about a given disease. That's what specialization and residency is for. It's how many do you know. And the illness script is literally the story, the classic presentation of a disease. It starts with pathogenesis. How does it work? How does it break? Step 1. What's the presentation like? And the initial diagnostic steps, step 2. Initial intervention and response to those interventions. What's the expected or anticipated outcome? Step 3. So that breakdown then is, that tells you, hey, step 1, step 2, step 3, focus on different things, different parts of the illness script. Since you have to know every specialty, not just the one you want to go into, you can't possibly know a lot about them. So at each stage, you have to know the classic presentation, the classic illness script at the phase you're learning. Now, the good news is when you start studying for one of these, you know which one you're going to take. And when you sit down for the exam, it's like, I'm here for step 1. You're not going to get follow-up and disposition questions. You're going to get mechanisms of disease. So an illness script is pathogenesis, patient presentation, diagnosis, treatment, and follow-up. You only have to know the classic presentation, standard, 0 standard deviations from the mean, but you have to know a shit ton of them because you have to know everything. So with that in mind, I'm going to progress as though nobody here has taken an NBME exam, no one's taken USMLE, no one has any idea. Now I know most of you have, right? You wouldn't be here trying to learn about it if you weren't at least aware of it. But I think it's best to start this way. This is a vignette, right? Starts off with age, gender, blah, 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 has a question and some answers, right? Now there's something unique about these. We'll get to this. This is the interrogatory. It helps if we use the right vocabulary. The interrogatory is the question you have to answer. The question you have to answer is based on a conclusion of the blibbity blah above it, called a hinge. Blibbity blah, blibbity blah. The question or the interrogatory is what you're asked. These are the answer choices. The good thing is one of the things that make it a fair test. The good thing is that on any question, there is only one right answer. The others, however, are not wrong. They are distractors. And a good question is written when a distractor could be right if, 2 things. First, it could be right if you only studied with flashcards and you saw the word wheezing and chose asthma. That's a trap, right? But good distractors are this answer would be right if you change something in the blibbity-blah. So it's relevant to whatever the conclusion was. It answers the interrogatory. It may actually be something you would do, but the other answers aren't the best. And this is actually what I really like about the USMLE. There's none of the above, all the above, multiple answers. There's one right answer. And the whole rest from A to the period before the interrogatory is the STEM. And in the STEM is where you get all the information necessary to make a conclusion, usually the diagnosis. And then that allows you to answer the interrogatory using the answer choice. That's anatomy. I think most of you knew that already, but I think it's important just to keep everyone up to speed. So, most of you are used to using commercial off-the-shelf resources, QBanks, right? And what you're used to seeing is all that anatomy is there. They got STEM, they got question, they got answer choices, and then they got explanation. What a lot of companies do is provide snippets. They say, this is the right answer because, and they say, these are the wrong answers. Here's some information about that wrong answer, which is actually the worst way to learn, right? Because all you're doing is like flipping through a textbook randomly at different sections, reading small snippets, and they're somehow loosely associated to a vignette. It's also not how the MVME writes. To be very clear, no one who writes for the MVME will ever work for a commercial service. The people who write for the MVME are academic positions. They're generally deans and professors. They're not going to get paid $40 for a question, right, by some QBank. And what's different is that the MVME has very specific instructions how to write questions. And so since the STEP exams are a multiple choice test, if you know how the questions are written, you know how to tackle those questions, the test becomes a lot easier. You still have to do the work to know the stuff, right? You still have to be smart enough to figure it out. But if you know how they're written, you know how to take the test. So the first thing, and actually I know this, not because I wrote for the MVME, but because I had mentors who did, right? Both for AVIM and the MVME, and they shared with our residency how this happened and forced us to practice this in residency so that we would do well on the AVIM. So I've had a lot of experience and mentorship, even though I haven't actually experienced it myself. And then also in the position at OnlineMedEd, we've got to talk to a couple of the deans of different schools who do this, so we kind of confirmed. The first instruction a question writer is given is determine the educational objective. What is it you want to test? Diagnosis of heart failure, diagnosis of heart failure exacerbation. What does a heart look like at 48 hours after myocardial infarction? Once they have the educational objective, their first task is to write the interrogatory. Now, you might have looked at that anatomy of the question and said, why is the blue one first? It seems to be in the middle of the thing. Why did you put it there? This is why, and you'll see how we're going to use it later on. So they're asked to write the interrogatory first, based on their educational objective. Then create the right answer, the one they want to be correct. Then come up with the distractors. Now remember, distractors are right if they're in the same realm. They have to be related to the interrogatory and to the right answer. You notice what's not here yet is the STEM. They don't write the STEM and then come up with the stuff. They come up with the stuff and then write the STEM. So the other good thing about all three steps is that there are no curveballs. Right? And if you notice, vignettes are only like this big. Right? H&Ps are 4 pages long. So they don't have the opportunity to say all of the things are positive and all of the things are negative. The goal of the STEM is in a very condensed form to let you draw the conclusion, to let you answer the interrogatory. You know one answer is right, which means that the STEM is written in a way that all these related answers could be right if the vignette was changed. So the stuff they put into the STEM has to be things that are pertinent to the 5 answer choices. Don't just randomly write some stuff. So basically everything in the vignette is useful. 2 things particularly. If the vignette says something is positive and it's like not like a routine, it's like, oh, that's a clue, right? But if they take the time to say negative, like a pertinent negative, that's like the answer. Either it's telling you that is the answer is A, or the other way around. We are completely ruling out one of the options because they don't have infinite spaces. All this stuff is negative. So the benefit of taking the USMLE is that the interrogatory is always asking affirmative. No nots, no accepts. There's only one right answer. the best answer. Sometimes you do all of them in real life, but there's only one best answer. And all of the answer choices are ruled in or ruled out based on the stem, and there's nothing else in the stem except that. That also means that if you're like reading a question and you're like, these 5 data points point to A, but this one word is a little off, throw that word away. Chances are you misinterpreted it. If you have a whole bunch of things that say one thing, go with that one thing. All right, so if you know how questions are written, educational objective, then the interrogatory, right answer, wrong answer, then the vignette, what order do you think you should do when you actually sit down at a question? Before I start this answer, most of you probably know the answer, but think about that time that you read that vignette, 74-year-old male, substernal crushing chest pain, you're like, I got this, it's a heart attack. Then you start underlining hypertension, diabetic, smoker, you're crossing off that, the whole vignette, go colorfully lidded, underlined, right? And you get to the interrogatory. What the fuck? And you have to erase everything. It had nothing to do with the myocardial infarction. Well, if you had listened to me, you wouldn't have had that issue. And I know this is a problem for people, right? So every morning at Morning Report, Baton Rouge General, we would have question of the day. And every day I walk in, where is the screen sitting? At the top. Answer choice is not visible. So I couldn't break the habit of reading the vignette from the start to the end instead of doing it my way. Now, one last piece. I say this part not to brag, but to illustrate how powerful it is. The ABIM does throw curveballs, right? So I'm the person who's seen the play 60 times. They can test me on whatever they want. It's a 9-hour exam, finished in 2.5 hours, and I'm board certified, so I passed. I know that I missed some things, like they tricked me because I did this really fast. And some people say, yeah, well, you're so smart. I mean, yeah, I am. I'm also very humble, but I actually don't know very much. Like, I actually am terrible at Jeopardy. I use methods and approaches to get through most of the things. So it wasn't because I was so smart or so knowledgeable that I was able to take this test and kill it. It was because I followed methods. And this is how I did it. And it's going to work for you as well. So since you know how the anatomy of questions, how they're written, and since this is a game of playing the game of the people who wrote it, do the test the way they do it. First step, read the interrogatory. Second step, read the answer choices. Now, you can't read the educational objective. Right? They don't give you that. That'd be too easy. But based on the interrogatory and the answer choices, you can have a pretty good idea what universe you're in. Cardiology, pharmacology, ketone, something or other biochem, right? And even if you can't get it all, you're priming your brain for what to look for. Right? And then after you've read the interrogatory and then the answer choices, then read the stem. The other thing about how question writers write questions is that they get into a room together. Right? They don't just be like, I'm a smart guy, put my question on the test, right? They have to come with the vignette, the interrogatory, the answer choices, and explanations why their right answer is right, and also why the wrong answers are wrong, and how they would change the vignette to make those answers right. And if they can't do that, the whole table, figuratively, of academics says that's not good enough, go back and try again. So you can be sure that by the time it reaches you on the exam, it's been vetted like 75 times through this process. So you know, even if you don't know everything about all the answer choices, you can start looking for things. And when you find things that are positive and negative, start underlining, striking those off, because that's going to eliminate a bunch of answers. Of course, the question comes when you have no clue what the hell the interrogatory is asking, and you're seeing a bunch of answer choices that you don't recognize. What do? Now, if you're answering honestly, you stare at it for 15 minutes, hoping the answer is going to come out of the computer at you. What you should do is press C, and flag it, and move on, right? So and you can get there not after the vignette's been read, but after the interrogatory and answer choices. You're like, holy shit, I have no idea what this is. Or if it's an acid-based question, flag it, move on. Right? When you finish the block of 30 that you know the answer to, you're like, oh, now great, I have only 5 minutes left to do these 10. And then you can stare at it for a little bit, right? But you wouldn't know that until you get through the whole way. And then you feel committed because you read the whole stem. You're like, oh, I got to figure this out. And then you sit for 10 minutes and you don't finish the test. So order of operations is super helpful because it takes you through the process that the MD question writers do. And if you do that, you start playing the game the way they trained it up, you end up doing better naturally. And what ends up happening is you can usually get the answer almost just reading the interrogatory and the answer choices, or you can say, like, these two are dumb. Like, it's really hard to write a question that has 4 good distractors all the time. And so there's usually a good way to weed them down and get rid of the questions that you don't know the answer to, push them along, or get down close enough where it's a 50-50 shot instead of 1 out of 5. And then, of course, if you actually did the work, there's a whole bunch of them you know the answer to. And that's the next part, score expectations. What should you do and how well do you want to do? And this comes down to a couple of things. It comes down to how well you want to do, how hard you're willing to work, and how long you're willing to work for. And the next 2 things are going to be about what you need to do in order to achieve those, and then also study schedules. Because what you want to do is train for fight day. You want to train for the test. Score expectations go like this. I'm not going to talk about negatives. We're only going to go positives. It's easy to do average, right? So if you just want a 230, you need to do the minimum of that amount of work, right? And that's something that most people know about. First aid in the Q bag, right? You do the same things that everybody does. You're going to see the usual things. The problem is, in order to get over a standard deviation or 2, you need to start studying things that you won't see on the exam. And if you just want to go for average, everything that you study, you will see. But there's going to be a bunch of stuff that you have never even heard of. And you're like, well, see, move on. I know how to do this. If you want to get into the 270 range, this is what I call augmentation. It takes a lot of dedication, and most people are not cut out. You have to study 10 things you don't see on the exam in order to see 1, and you don't even know you're going to get it right. And that level of commitment is a lot. If you need it, you got to do it. Most people aren't able, but a lot of people can settle for the advanced stuff. And so advanced means into the 1 standard deviation above the mean. You have to study a lot of stuff. You're going to get to the test, and you're not going to recognize everything. Press C, move forward. But there's going to be a lot. You're going to study hard, and you're going to feel good because most of the questions you're going to see, like, I know this, or I know get down 50-50, and then half, you're like, I know. That's easy to do if you work a little hard. Depends what your goals are. Remember that P does equal MD or DO, but P does not equal residency. So getting below the mean is not great. If your aspirations are do internal medicine, family, right, all you need is average. But if you want to do derm, you probably need to augment. So it depends what your goals are, what your realistic expectations are, and how hard you're willing to work. And that comes down to study schedules. That's about the phases of learning. I'm going to talk as though I'm speaking to step 1 people only. Gave a talk at AMSA about step 2, and I showed how this process could actually work for step 2, except the learning phase is your entire year. Right? You go through your clerkship studying diligently, and then on test day, you don't have knowledge bulimia. You actually retain it all and then review it. I'm not going to go into that. If we have time for the Q&A and you want to know more, we can. But the phases of learning are going to be for step 1. Easy to understand. Behind you, classes, they're over. Ahead of you, clinical. Most schools give you dedicated time to do nothing but study for step 1. And I break this down into 2 phases, really 3, but the third one's sort of 2.5. It's the study phase and the taper phase. The learning phase is in blue, 6 weeks dedicated. And then towards the end, you're going to start to taper on towards test day. Now, a boxer gets into a ring on fight night, spends 9 rounds, 3 minutes apiece, beating the shit out of some other dude's face with his gloved up fists. Think of every boxing movie you've ever seen. In the training montage, how many times is he getting hit in the face with a glove or is hit someone else? The answer is probably not at all. They see him skipping rope, right? Speed bag, lifting weights, running in sweats by the river, right? Why isn't he in the ring punching a guy in the face? Well, because he has to develop the speed, stamina, agility, and strength in order to sustain the fight on fight night. And if he fought every day for 8 weeks, probably going to end up with brain damage before the fight. So too must you do the same thing with your mental athletics. You're going to spend time doing things not test related, learning, jumping rope, and that speed bag, right, running by the river. And then as you get closer to fight night, you're going to start to taper. You're not going to train as hard, and you're going to start doing the things that resemble what you're going to do on test day. So the learning phase looks like this. Monday through Friday, you can pick whatever days you want, just convenient to do a 7-day schedule. Monday through Friday, you're learning new stuff. Whatever method you choose is up to you, but you're bringing in new information. You haven't seen it before. You are rigorously learning whatever resources you have, and you're taking your own notes to consolidate. On the weekends, though, you got to take a break. Most med students don't know how to do that, so what I recommend is instead review. And what you should do is review only the material you've done so far. This is purposeful repetition, and it's easy in the beginning. So you begin to ramp up how much review you're going to do. So the deeper you get into it, the harder it becomes. And if you start off kind of easy, it's like, oh, it's not that bad, and you slowly increment how much you do. As the learning phase comes to a close, you begin to start to taper. I was a swimmer, so I'd like to set this example. When Michael Phelps swims to the Olympics, he trains really hard all year, but not a month before the race. If you train hard before the race, you may still make gains, but you're not going to be fully prepared on the race day. If you don't do anything, you're going to forget how to swim, you're going to lose all your stamina, and your muscles are going to get cold. So you have to do the thing that you're going to do on test day, only not as rigorous as you've been doing it. Taper phase. Get up at the same time, eat the same thing at the same time. Do 7 blocks of 40 questions. Turn off tutor mode. Anything you learn in the taper phase, something else has got to be displaced. All you're doing is trying to get a feel for how you're going to do on test day. Like, when do you get fidgety? When do you lose attention? When do you want to shit yourself and you just want to run around the parking lot for 20 minutes? Right? You've got all this break time assigned. You don't have to break it up evenly. Figure out what you need to do. When do you need to eat the granola bar? When do you need to go to Subway for an hour? And if that's what you figure out you need, that's what you should do every day until test day. But don't forget to take a break or review. And the week of the test, take 2 days off. No one can do that. That's fine. But I recommend you do nothing. But if you're going to do something, don't do anything except review the hard shit you're not going to remember, like rheumatologic antibodies, right? There's no way you're going to remember that. So do the things that are strict memorization that if one last look's going to maybe help you get it on test day. All right. So we talked about anatomy of the question. I think most people know that. How MBME question writers write it. That's probably the insight you were looking for, and therefore how to actually tackle a USMLE vignette. Setting expectations, how hard you want to work, what are you going for, and then the different phases of learning in order to get you ready for test day. This is the resources that you can use. 2 minutes and then I'm done. Books, there are 3 kinds: skin, muscle, and bone. Bone are the review materials. Don't read those until you've done the material. You're only looking over stuff. Skin books, don't touch them. Harrison, Cecil's, Up to Date. Those things are too in-depth. You don't need to see the play 60 times. You need to know the common presentation of all diseases. Pick a reading book, prose, that means full sentences, and pictures that you can actually get through. Lectures, OnlineMedEd is free, hooray, right? But most people don't want to dedicate the time to do all that. So if you learn that way, find a series that works for you. If you're going to use a Q bank, I recommend 2. 1, because you want to learn. In the learning phase, turn tutor mode on. Doesn't matter what it looks like, as long as you learn. Taper phase, get a second one that simulates the exam. It looks and feels exactly like the actual test. Doesn't matter what quality the questions are. You're not looking at the answer explanations. Just do it because it looks and feels the same. Final word of warning is flashcards. Do not learn with flashcards. Learn the shit first. Make flashcards. Use flashcards to review. And that's how you beat USMLE. All right, Joel has prepared something for me, and I have had the slides, but I promise I've not looked at these. This is going to be literally Dustyn under the gun here. All right,
yeah,
Joel, what do
absolutely.
I do?
Yeah, thanks for that, Dustyn. I really appreciate it. I think I just want to reiterate everything you said. I think it's just really important and really useful. It's very interesting working with, more than 50, 60, 70 of our tutors who have all scored in the top percentiles and working with all these students. Everyone kind of on their own came to a same or similar conclusion. And a lot of these things are things that Dustyn just shared. And so kind of take it from him so you don't have to flounder through it and figure it out on your own, but take the advice, apply it, and I would imagine that you would see similar results. And I can also guarantee that Dustyn has not seen these questions, so they will indeed be a real challenge, or might be a challenge, but they're definitely going to be new to him. So we'll go ahead and start with our first question here.
We hope they're not step one. But let's do it. I'm ready. All right, first question. Okay, now everyone's already reading a 4-year-old boy, and stop reading that. What do you do first? Which of the following is the most likely mechanism? Step one question, terrific. What are these findings? Adenosine deaminase, that's TB. Dysfunctional opsonization, okay. Consumption of complement. This is so I already, it's a microbiome question, right? It's the mechanisms of microbiome, or maybe immunology. Impaired chemotaxis, development, arrest, maturation of B cell destruction, CD4 positive lymphocytes, impaired phagocytic oxidative metabolism. All right, so we're talking about immunology, microbiology, probably something to do with phagocytosis and adaptive immune system. People who are studying for step one probably can be more. All right, now I'm going to read this down. 4-year-old boy was brought to the clinic by his parents with a history of fever and painful swelling of the right ankle. He has had recurrent cervical lymphadenitis and pneumonia since infancy, immunodeficiency disease. 1.5 years, culture for an abscess in the cervical region grew Staph aureus. Temp now is febrile, tender, edematous right ankle, tender to palpation on the medial. Malleolus, bone scan shows increased uptake to the right tibia. Culture, thank God, of bone aspirate shows serratia. Nitrotetrazoline, I thought that was going to be the answer. Shows no color change. That's a pertinent negative, right? Nitro blue. That's the answer. Ha! Nitro blue tetrazoline should turn blue, but it doesn't turn blue in one disease. Now, if I knew what it was, I'd be one of the things in phagocytosis is the first step. I think it is chronic granulomatous disease, or the other one, but it's impaired phagocytic oxidative metabolism, G.
So that is indeed the answer. So the answer is going to be chronic granulomatous disease, and it's due to impaired phagocytic oxidative metabolism. So an impaired ability to essentially destroy phagocytose bugs and bacteria. In this case, the one thing that I think Dr. Williams had also noticed was the negative nitro blue tetrazoline test.
Now, the full disclosure, I actually am working on the step one content, and I did immunology like 3 months ago. So when I saw the nitro blue test, I was like, I have no idea. Everyone who just read a 42-year-old woman, slap yourself. Which of the following is the most appropriate next step in the management? CT abdomen, CT scan of chest, thoracoscopy, laparotomy, or thoracotomy. So obviously we're dealing with palm in the chest, probably pleural effusion. 42-year-old woman is brought to the emergency department 10 minutes after being involved in a high-speed motor vehicle collision. Strained passenger. She has shortness of breath in the abdominal vein. Pulse is 135, respiration is 30, blood pressure 80/40. That's not good. Breath sounds are decreased at the left lung base. An X-ray of the chest shows opacification of the left lower lung field with loss of the diaphragmatic shadow. Placement of a chest tube yields a small amount of air followed by greenish fluid. Okay, so I was all about ready to, this is why you read the interrogatory first, because I was all ready to answer a question about hypotension and what you do next in order to stabilize. But the greenish, so she's got a thing, has a motor vehicle collision, has a thing. We already put an intervention to drain some stuff off. Greenish fluid, that's probably the key here. Laparotomy would be in the abdomen. I don't want a CT because obviously we need to intervene. So like take the diagnostics off. And this is actually a mixed question. It's one of the hardest ones. What's the next step? We need to choose between a diagnostic or an intervention. To the same sense, a thoracoscopy is going to be a diagnostic step. Throwing that out, you need to choose between laparotomy and thoracotomy. All right, that's 50-50. I literally have no idea. It's probably, it's kind of going to be tricksy, and it's going to be laparotomy because I think it's in the chest, but I'm going to pick thoracotomy because it's inner lung. I knew it, but I chose it.
Yeah, so I think,
Yeah, but I got it down to 50-50 and I went for it. And I couldn't tell if this is like a real question, if Joel wrote them, or he was trying to trick me or not. But that's actually not a trick. I mean, that's like, I got it down to 50-50 and the vignette said chest, and I should have known better because nothing's green in the chest. Joel, school me.
Yeah, no, so I think, it's really interesting to hear you talk through everything. It's kind of nice to see you apply, your own steps, brought it down to 50-50. I think, really what happened here is, so, like Dr. Williams said, there's some sort of trauma, something's going on. The greenish fluid is telling us it's likely coming from the abdomen, some sort of ruptured GI, maybe the stomach because it's on the left side, but the problem is coming from the abdomen, likely also had a ruptured diaphragm, which is causing the fluid and junk to get up into those lungs, which is going to give you the decreased lung sounds and the opacification. So laparotomy. Dr. Williams, can you tell us why not CT of the abdomen or CT of the chest?
Well, so she's screaming intervention, right? Like she's heart rate's 135. She's frankly hypotensive. That's a major shock index. She's only 42, but like she is sick as shit. So the diagnostic step probably would actually be almost done in real life, like on the way to the OR. But when you do one of these questions that makes you choose between two, if the person is unstable, it's action. If the person is stable, it's diagnosis.
Absolutely, and that's the kind of information you get by doing things over and over again and creating these illness scripts, like Dr. Williams mentioned. She is clearly someone who's sick and is going to need an intervention, so should do that right away. Nice.
The green fluid is really what did it. That's and I didn't listen to my own advice. Right?
So these are real questions too. I did not make these up to throw you curveballs.
All right, next question. Which of the following is the most likely diagnosis? Wow. Bacterial meningitis, dextromethorphan intoxication, herpes simplex, encephalitis, HIV, encephalopathy, Rye syndrome, syphilis. Isn't those two different things? All right, so this is obviously a brain inflammation question, probably altered mental. Before I even read it, bacterial meningitis is going to be an LP, thousands of polys, dextromethorphan intoxication, pinpoint pupils, nothing on the CSF, herpes, syphilitis, MRI, whatever, the temporal lobe and blood and the LP, HIV encephalopathy, risk factors, she's got AIDS, and Rye syndrome, syphilis. Probably
those should be two answers. Those should be two answer choices. Yeah.
I think Rye syndrome is actually like in kids who take aspirin, so that's cheated. She's 22, and syphilis. We'll get to that. All right, so the vignette is previously healthy 22-year-old college student brought in the emergency department by her parents 20 minutes after they observed a seizure. After the seizure, she was confused. That means post-ictal, so she had a seizure. Has a headache, cough, fever for 3 days, treated with acetaminophen and dextromethorphan. So dextromethorphan does not cause a fever and seizure, strike off B. Temperature is 102 Fahrenheit. She's got diffuse hyperreflexia. Mental status examination, so that's not really relevant to our answer choices, but hyporeflexia would be like West Nile encephalitis, but that wasn't an answer choice. Mental status examination, she is confused, short-term memory deficits, naming objects, and makes literal paraphrasing error. Here we go. Bitemporal hyperdensity. Oh no, not of the hippocampus. All right. Lumbar puncture, so it's going to be easy. Lumbar puncture, so if they mention hippocampus in the vignette, it's herpes. A lumbar puncture is done. CSF shows bloody, a leukocyte count of 121 with 88% monocytes. Monocytes, okay. Protein concentration is 78. So it ruled out bacterial meningitis, not thousands of polys. It's bitemporal screams to me, HSV, even though it doesn't say hippocampal lesions. They didn't mention a VDRL or RPR. So syphilis is out. If they don't give you information, then you can assume it's negative almost always. So didn't give us any information about opening pressure or Candida, India ink or cryptococcal antigen or an HIV status. So HIV is out. So we're down to, I did it right. So I rolled out bacterial meningitis, no polys. Dextromethorphan doesn't do this. HIV, no risk factors, or CD4 count given. Rye syndrome, not ultimate. Syphilis didn't give us an RPR. I did not think it was going to be herpes, but it is because that's the only one that's left. I expected to see a lot of blood and lymphocytes, but this was more of an exercise of elimination. So C. Okay, good. I got 2 out of 3. That's great. Literally bad.
Yeah, exactly. So the like you had mentioned, the age kind of puts you in the category. The encephalitis syndrome, the kind of signs and symptoms, the confusion, the seizure, and then really, as you had noticed, the bitemporal hyperintensity disease is really what's going to get you. What do you think? You know, when you look at the LP and you saw monocytes, what are you thinking when you see monocytes in the LP?
Literally nothing. I was worried so like that's why you read the answer choices in interrogatory first. If I just read that vignette, I'd be thinking like, I don't know, a weird thing that I don't usually teach. So I literally have no idea what monocytes would imply. Does it imply herpes?
Yeah. So it can, but I think the thing that you kind of took out is it's not bacterial, right? Because bacterial meningitis, you'd see something, you'd see different. You'd see neutrophils.
Right. And a lot of them, like 1,000, like almost close to 4 digits, and they're all polys, right? And that's actually the good thing with the lumbar puncture, especially on the test. It's not going to be like 250 cell polys. It can be like 957, 99% polys. That's bacterial, right? And then if it's not that, it's and they'll give you more clues. Actually, you know, monocytes, I probably, if they put on something like Rocky Mountain spotted fever or, you know, one of the rickettsial things, I might have been suckered into that because the erythrocyte count wasn't high enough. And this is actually like real medicine. I've had plenty of patients who've had no blood in their tab have HSV encephalitis. So that isn't something that's true for life, but almost always on the test, you're going to see blood with HSV. I expected to see a little bit more.
Awesome. Okay. Well, thanks, Dustyn.
Yeah,
so I'm just going to, I won't spend too much time on these slides. I just want to talk briefly about what OnlineMedEd coaching powered by MedSchoolCoach is. We are a tutoring service. We provide one-on-one tutoring. There's a lot of things that we can do. It's easier to say what we can't do. We can't take the test for you. But other than that, we can start with you from day one and take you all the way up to the exam. We can help make study plan with you, help select resources, do content review, and work on questions. And oftentimes, actually, I spend sessions doing similar to what Dr. Williams and I just did. We go through questions, we talk through thought processes, we talk through strategies, and then I try to help encourage the development of illness scripts by doing that. So we can go to the next slide. There we go. Oh. All right, so I think one of the most unique things that we do is we offer a really personalized one-on-one experience. So there are a lot of books, there's question banks, there's videos, there's lectures, but oftentimes it's very hard to kind of get one-on-one attention. I know in my medical school, I don't think I ever had one-on-one attention. It was, you know, at the most maybe 12 medical students to maybe a single professor. So it's really nice to get one-on-one attention. It's really nice to have everything personalized to you. Do you want to say something, Dr. Williams?
There was not enough histology professors to fill the histology labs. We taught each other.
Exactly. And so it's really nice to have a one-on-one experience. There's not every resource is the best for you. And it's useful to work with someone who's really experienced with this, who has done well, who has a very extensive history of teaching and education, kind of walk you through these steps. These are some things you can do. I won't go into too much detail for them, and I only have one more slide. A common question that I get is, well, how does tutoring actually work? What, you know, is this like a program or what is this? So the way it works is if you were to sign up or enroll with us for some sort of tutoring package, you then get paired with a tutor. So first you get an intake form. You fill out that intake form. It has a lot of questions to try to get to know you. Have you taken the exam before? How has medical school been? What are your goals and your expectations? What resources have you used? And several other questions to try to get a sense of who you are and how we can best help you. We pair you with the tutor, and then you meet one-on-one with that tutor. Everything's digital, very similar to what we're doing right now. And so it's the availability, and when you meet, it's very flexible. We then will have your tutor work with you to make a study plan and select resources, and then create a plan to utilize your guys' time together. This will then be really flexible. So they're going to try to identify what you need help with and try to give that to you. Sometimes it's content review. Sometimes it is question-taking strategy and several other things, but they're going to be the ones to identify it for you. And our goal is the same goal as you, to have you succeed. to have you score as high as you can so that you can do whatever you want in medicine. And this one or these two numbers are not going to limit your choices of residency. Like Dr. Williams said, you are not defined by this number. So we will go ahead and dive into the question and answer. So thank you for sending over your questions. We have a lot of good questions here. I'll go ahead and let me find us a good one for us here. I'll send this one to you, Dr. Williams. What advice will you give for the exam day, time management, etc., how you use your breaks, and then kind of how you manage your anxiety and stress?
So manage mine, I don't have any. I practice and rehearse this so much that it's easy. So I think it's more important for you during the taper phase to find out what you do, what's you, right? So if you ask me, it's take every block back to back, don't take breaks, finish as soon as you can, to suck them on out. But if you try to do that and you are anxious, you need the full time, that you're going to die, right? So don't listen to my advice about what I would do. You need to find out and by actually rehearsing it, right? So you may not need 2 weeks to do it, but you should definitely do a few days where you get up at the same time, eat the same thing, 7 blocks of 40 questions, like you're doing it on test day. No tutor mode, like you're there. You can't simulate the experience to check in and check out and show me your wrist and all the stupid shit they do. But that only takes like 2.5 minutes, right? So be friendly to people when you get there. Wait patiently, because if you piss them off, they'll make you wait. But if you don't piss them off, it gets you back. So it's really about figuring out where you break down. If it's 3 blocks in, you need 2 hours, and then you can finish all 4 blocks. Do that. If it's you need 20 minutes after each block to cool down, calm down, grab a snack, do that. So it really comes down to figuring it out. And if you can't figure it out yourself, you're going to need someone else. Because if you, and this is actually, I didn't say this in the talk, when you find the resources that you want to use and you've developed a schedule, don't listen to anybody else except me. I'm telling you this right now. Right? So if someone else tells you, oh, on test day, you need to do this, be like, no, I don't. I figured it out. I'm going to do it my way. Don't listen to other people, because everyone else has a way, and it's their way, not right for you.
Great. Is there such a thing as starting too early for studying for step 1 while still maintaining a balance with med school classes? So I guess timeline of when you should start studying.
Remember, it's about peak, right? So like the learning phase and the taper phase come at a point where you schedule step like 6 months in advance, right? And your study time is 4 to 8 weeks. And so the goal is, in those 4 to 8 weeks, be on your way up to your peak, take it now, or right on your way down, take it here, right? You don't want to start too soon to take the test because you're not ready, but at the other time, if you take too long, you just burn out. So starting too soon is not a thing, as long as you pace yourself, right? If you're just like, I'm going to watch 1 video a day for 2 years, that's cool, right? But then as you do that, you need to start ramping up as you approach the test day, right? Just like the montage, you need to start training hard in the learning phase, very close to test day, and then figure out where that taper phase is 1 to 2 weeks out, so that you are peaking. Now, at the same time, you have to balance that with your life, right? Med school is not everything. Step 1 doesn't determine everything. So if you're like bogged down by schoolwork and it's the 2nd month, 1st year, chill out, right? Go to a block party, right? Have a beer. But if it's the 2nd semester of 2nd year and step is 3 months away, you could go ahead and turn down that invite to the restaurant and go ahead and start studying. So yes, it is a thing starting too soon if you work too hard. No, if you learn how to pace yourself. And so that's actually really hard for a lot of people to do. So I generally say, sprinkle it in and then get ready to train. But again, it's going to be individualized to individuals.
Yep. Great. I also think, when you are in medical school and you're studying and learning these things, you are preparing for these exams. So in your cardiology block, when you're learning about heart failure, that is still applicable to step 1 and step 2. So don't feel like you're somehow splitting your time in a sense, because they're both relevant and applicable. I mostly have to choose between 2 possible correct choices. How to eliminate the wrong answer in that case?
Well, you just watched me fail at that, so I don't know. So seriously, if you're down to 2 answers, pick one, move on. Right? Like if you're that close, you got it. Like on that question I just screwed up, like I saw the green fluid and I was like, chest, not green fluid, I'm not going to fall for it. And I picked the answer that the vignette was leading me towards, and I didn't stop to consider that one data point. So I think that this is what I actually did on my ABIM. I remember one question, like multiple myeloma, I want SBEP. It's not there. Fuck, serum immunofixation. Did not know that was called, so I didn't pick it. So I know I got that answer wrong. And at the same time, when I got down to, man, you know, like it's one of these, I just picked one and moved on. Now, if you feel like you're doing that every time, you need to stop and slow down, flag them, and go back to them. Because chances are there's something in the vignette, like the green fluid, right, that told me which cavity to go into. So if you're down to 2 choices, you're doing great, right? Chances are you're doing one of 2 things. Either like I did, you get tricked by the vignette, or you are doing that data point thing, right, where you find one thing that doesn't fit with the rest, and you're like, oh, it can't be the right answer because it's one thing, get rid of that. I actually did that, and it failed me with the green fluid thing, but for the most part, if you follow the guidance of the vignette, you're probably going to be guided to the right. That's about it. Except, actually, the other thing is, you can get answers wrong and still do really well, right? So if you're down to 50-50, that's pretty awesome.
Yeah. We always tell folks that you don't need to get 100% to do well. And really, it's your goal just to get as many points and put them in your bucket as possible and then move on. What is your approach to physical exam findings or history details that are left out of the STEM that are really important to getting the right answer? Do we assume they are negative?
I don't think you should assume they're negative. I think you should assume they're normal. So if you're expecting them to be there and they aren't, they're negative. If you're not expecting them to be there and they're not written, they also, I guess it's negative, yeah. I mean, I think I would say that 2 things actually. One, you think you need that and it's not there, you don't need that. But in general, I would say that if they didn't take the time to say that it was negative, assume that it's negative. Right? Or like neutral to the diagnosis, right? So like if it being not there is like, oh, that means it's the answer and it's actually not written, assume it's not the thing you need, right? Just assume it's neutral, which generally means negative. Joel, is that what you coach people?
Yes. Yep.
Okay.
Should I weight my studying of particular subjects based upon USMLE blueprint or percentages of question subject types? So I guess the question is asking, should you weight your studying based upon what you think is more or less important?
I mean, don't go out of your way to study every one of the MEN syndromes for a day, right? The blueprints are stupid. Everything's 1%, which means know everything. Jamie, my co-founder, is actually at a conference right now, and there's a poster that said, what happens if you choose your studying based on what you think you're good at? There's actually a negative correlation with good outcomes. And that mirrors what I think. So whenever I did any of my studying for any of my exams, it was everything. The danger of that is people fall into the trap of studying what they know really well. Like, don't study anemia for the 17th time because you know anemia. Like, if you know you got the back of your hand, skip it, move on to the thing you don't like. Right? But I've always taken the mindset of, doesn't matter how well I think I know something, doesn't matter how well I've done on a previous test, study everything equally and listen to somebody else, right? Like, review resources, tell you what's important, right? 3 minutes on MEN syndrome, 25 minutes on COPD. You should probably study more on COPD. So study everything, but make sure you choose the right resource that guides you in the right direction.
Yep, absolutely. Especially, it gets back to your expectation. If you want to do, orthopedic surgery or something, and a high score is your goal, then everything really then becomes important as long as you're using the right resources. Excellent. What is the best way to evaluate your progress during your study so that you are ready to score well on the actual exam? So how do you track progress?
I don't. Remember, it's all about peaking. So if you've laid out a plan where you're going to be in the learning phase, you should not be evaluating yourself because halfway through you haven't learned half of the shit, right? So for me, it's about choosing an exam date, then doing the learning phase paper and trying to hit at your peak. If you're not sure, you should get some commercial resource, which is like a surrogate approximation of how you're going to do, right? So the only thing I would recommend is if you think you're peaking and you score 50% on an NVMe practice test and the predicted score is 190, you can pull the cord and not take the test. I don't usually counsel people on study strategy more than I have already. So actually, like I kind of, Joel, what do you do? What do you ask your people to do? Because I would say don't, because my study strategy is study, take it easy, test, right? And it's like, well, you gotta get what I'm getting.
Yeah, I think it's situational. So I think it depends on where you start off at. Some students are who have a goal of passing and they're really trying to get to that range. Our general advice is to take it a week or two before. If you're happy with that score, or if you got that score and you would be okay with it, then go ahead and move forward, unless you can't delay. So I mean, if you can delay and you're not happy with that score, then go ahead and delay and continue to study. But I also completely agree. I never recommend taking a ton of NVMEs. If you take one right when you start studying, probably not going to go well because you haven't been studying. I think it's kind of nice maybe to take one a month out and then maybe a week or two out, just to kind of get a general sense of how you should be spending your time. Do you need to spend another extra week or two, or are you good to go?
And actually, I'll throw in a little advice as the program director, associate program director. A fail on step one is way more of a red flag for any exam than is you took 2 months extra to finish, right? So if you need the time in order to succeed on the test, take the time. You can make up elective time. You might have to explain it in your personal statement, but no one's going to read it anyway. You got a low score or a fail, ERAS screens you out, right? So it's I've actually told people that they can take an elective with me to study, right, so that they stay on target, because like they're freaking out about it. They're going to take the test too soon, they're going to fail. Like, dude, like that's dumb. So as much as I don't want the test to be the deciding factor on who gets into residency, that's the way it is. So if you're going to make the decision to take a test because you want to finish on time versus get into the residency of your choice, delay and get into the residency of your choice.
Yeah, absolutely. We always tell people, when you do it right, and try to do it right the first time. You don't want to get in the cycle of having to repeat the exam or delaying. Use the right resources, get the help early, and do it the right way the first time and be done with it. Great, we'll do one more question and then we're gonna have to close out. The question is, I always think the question is trying to trick me. I never think the simple answer can be right. Are there ever actual tricks?
No curveballs in step 1, 2, or 3. Remember, the question writers start with an objective, interrogatory, answer choice is the distractor. They think it's going around the table 25 times until every academic who's a professor is happy with it. The purpose of the step 1 and 2, and even 3, but definitely 1 and 2, no curveball. All of the data points, except for the green fluid, right, is pointing you in the right direction. So every once in a while, you might get a piece of information that doesn't fit. And I should have been smart enough to know green fluid doesn't come out of the chest. But if you follow my method, you get 2 out of 3. It's pretty good. So if you're a super good test taker, maybe you can read between the lines. But what I did today was strictly how I do it, which is follow the guidance of the vignette. They're not supposed to trick you. And chances are, if you think you're being tricked, you're tricking yourself.
Well, great. Thank you, Dr. Williams. Everyone, this was a wonderful opportunity. I'm going to go ahead and turn it back to Dr. Mehta, who's going to say a few things and close us out, and also give you the name of the cat.
Yeah, don't leave yet, because I know you guys want to find out the name of Dr. Cat, and that's coming up. I want to say a couple of things. I was listening along with this whole webinar, and I am 10 years away from step 1 and step 2. I didn't remember a thing about the questions, but if you go through it like Dr. Williams did, you can actually figure out the answers even 10 years out, because you actually can understand, okay, this is what they're getting at. So amazing advice. For those of you guys who are out there who are about to take this test, or going to take step 1, step 2, and anytime in the next couple of years, these tests are necessary evils, right? I mean, as Dr. Williams said, they are sort of, out there. And probably the thing that residencies look at. As a program director myself, it's so easy for me to sort through ERAS and see what scores are. That is the easiest thing for me to do. And it's honestly, unfortunately, the first thing I do. And that sucks. It does, but that's the reality of sort of the world we live in. So you guys really got to make sure you score high on this. And OnlineMedEd is such an amazing resource. Dr. Williams has created these amazing videos and question sets and everything else that goes along with it. So if you don't have that, you're really losing out. You got to start with that. And for those of you guys who need a little bit more help, aren't getting the score that you need, OnlineMedEd coaching is where you want to go, because we can really get you even higher, really sort of hit on that one-on-one aspect and make sure you're figuring out where your strengths and weaknesses are, and almost take you through in some ways what Dr. Williams did today, but in your own mind, right? Your own brain. What is it that you're doing wrong? That's what our tutors are so good at. So thanks again to Joel and Dr. Williams for putting this on. I think this is awesome. I'm going to share a couple of things here, and I think this is the most important thing that you guys are going to learn in the entire day here, which is that Dr. Kat's actual name is apparently Kimber. I learned it today. Now you guys all know. It's a trivia question. Probably not going to show up on step 1, but maybe we'll show up on step 2. So keep it in mind. But really, thanks everybody for joining. I know a lot of you guys are asking for recordings, and there will be recordings online. The best way to get to those recordings is to follow us on Instagram. So it's instagram.com/MedSchoolCoach and instagram.com/OnlineMedEd. So make sure you follow those. We'll be posting links there as well as on YouTube, and you'll get an email as well. So follow us. You'll get all kinds of links as well as the recording to this webinar. But thanks everybody for joining in. We hope this was helpful to you, and drop us a note, drop us a line if you have any questions as we go on. All right. Good night, everybody.